moderator of his zone, Dr. Vijay Kumar, with the very enthusiastic moderator, Dr. Kundan Kumar Sarkar, who was the past president of his zone USI also. So I welcome all of you, sir, for today's class, and I will request, I'm requesting Dr. Randeep Prasad Singh to welcome all the dignitaries and the students to start today's class right to the time. Dr. Randeep Singh, please. President, sir.
The moderator,
Hello.
Dr. Kalyan Sarkar.
Yes.
Hello.
Yes,
Yeah,
yes.
you are audible, sir.
Okay. So this evening we are going to discuss the renal cell carcinoma, the first part which we have decided, and with the labor done by Dr. Kalyan Sarkar and Dr. Ranjan Dey, I think it will be a grand success. We started the tumor genesis from the tubules, tubular cell, proximal and distal tubules, and then we are now going to the lot of changes, the changes in investigations, the management, and now the genomics. So let us see that how we proceed and how the students do. We expect that to do better in the exams and prepare for a good consultant or good teacher in the life. All the best. Please go ahead, sir.
Thank you very much, sir. Now, I will request Dr. Kalyan Sarkar sir, to introduce all his colleagues, teacher today for this evening and to start the program. Thank you, sir. Dr.
Good
Sarkar,
evening,
sir.
good evening, President, Sir, Dr. Ranveer Singh Prasad. Good evening, Ranjan, Secretary, Eastern Section USI. And it's my great pleasure and honor to be moderating this session today, this East Zone Weekend Online Class on renal cell carcinoma. Now, just some house rules before we start. I think we've distributed the program, and I think all the faculties and the students participating have been informed about their roles. And without much delay, let us go ahead with the program. Now, similar programs have been held in the last few years, and this program we have tried to refine on the previous year's programs. So
it's 7 o'clock.
So today, the first Saturday evening session is going to be on 4 presentations by the students. Each presentation will be for about 12 minutes. At 10 minutes, we'll try to warn that the presentation has to be concluded, and this will allow 3 minutes for consultation. Our expert today to conduct this session is Professor Vijay Kumar of Patna, who is here. Of course, all the teachers are here, and each student who's presenting has been mentored by a particular teacher. So let us start with our first presentation. This is on nephrometric scores and their clinical application. Dr. Kunjan Kumar is the presenter. His mentor is Dr. Samir Swain. Now, I think the postgraduates had been given the brief of preparing the presentations exactly as they would answer answer a 10-mark question in their theory exams. So Kunjan, will you now share your screen and carry on with your presentation?
Am I visible, sir?
Yeah, very much so.
Thank you. Good evening, respected teachers and my honored colleagues. I am Dr. Kunjan Kumar from RG Medical College, Kolkata, and today I'll be discussing nephrometric scores and their clinical applications. Let us come to what nephrometry is in the first place. As defined by Kutikova and Uzzo, who gave us the renal score, who proposed the renal score, they define it as a structured and quantifiable method to describe a tumor's relevant anatomical features as they relate to its complexity. What it is essentially an objective assessment which is standardized, reproducible, and gives us a precise system of reporting renal masses. How it is done? We obtain high-quality multi-phase abdominal cross-sectional images in different planes for optimal characterization and staging of renal mass. For our purposes, this is basically usually a contrast-enhanced CT scan. The most commonly used nephrometric scores include the renal score, the Padua score, the simplified Padua renal score, also known as the SPARE, the centrality index or C index, the CSA or contact surface area, the nephro, and other relatively less commonly used scores such as the ABC, the MAP score, the DAP score, etc. Let's see why we use nephrometry. Now, as we know, with the advent of advanced imaging, including CT and MRI, as well as ultrasonography, incidental renal mass detection is becoming increasingly common, with up to 30 to 40% masses often being detected incidentally because of imaging for some other indication. Nephrometry is what we use to characterize the anatomy. Because nephron sparing approach is now considered state of the art, what nephrometry essentially helps us, the urologist, to do is it aids us in surgical decision making. Whether we want to go for a nephron sparing approach, whether we will have to use a radical approach, minimally invasive, open, robot assisted, laparoscopic, all of these nephrometry helps us to decide what we are going to use. It also predicts perioperative as well as postoperative outcomes and complications. It predicts postoperative, the extent of postoperative renal impairment, and it may be able to predict the tumor histology or the grade. It has been seen that papillary RCCs are generally have a lower nephrometric score, while clear cell RCCs have a higher nephrometric score. And the last thing it also helps us in is that it enables us to use the same language across different clinical disciplines, including radiology, urology, and other surgeons. So let's come to the most commonly used score, which is the renal score, which stands for, the acronym is R for radius, the exophytic nature, the nearness to collecting system, anterior, posterior, and the location. Each of the R, E, N, and L parameters are assigned one score, a score for between 1 to 3, and the anterior or posterior is depicted by A or P, or X if it is impossible to qualify the tumor as either anterior or posterior. In the same way, the location relative to polar lines, the L, is sometimes we use the H qualifier here, where the tumor is hilar, touching the main renal artery or vein. Low complexity tumors are considered when the renal score is 4 to 6, intermediate of 7 to 9, and higher complexity tumors are 10 and above. The Padua score uses 6 parameters. It is the preoperative aspects and dimensions used for assessment of renal tumors. It was proposed by Ficara and others in 2009. Now, the renal and Padua have both been used and validated extensively. They are both able to predict the warm ischemia time, the surgical margin negativity, the extent of complications, operative time, outcomes, and the success of partial nephrectomy. The difference between the two is that the Padua score also uses the rim location parameter as well as the collecting system, as well as the renal sinus involvement, which is not used in renal. However, it has been seen that Padua, because of its 6 parameters, is a little difficult to calculate. So the same team that gave us Padua came out in 2016 with the SPARE, or the simplified Padua renal nephrometry system. It has similar predictive ability compared to the renal and Padua scores, while using only 4 parameters of tumor size, exophytic rate, renal sinus involvement, and rim location, as we can see here, with a low score of 0 to 3, intermediate being considered 4 to 7, and high tumor complexity of 8 and above scores. Then we come to the zonal nephroscore. It is we use 4 variables here: the nearness to the collecting system, the physical location of the tumor, the radius, and the organization, each being scored from 1 to 3, and which gives us a score. Again, a low risk tumor being 4 to 6, and a high risk tumor being 10 and above. And now we come to the C index and the CSA. The C index, which is basically the centrality index, was proposed in 2012 by Simmons and others. It is the ratio of distance between the tumor center and the kidney center with the tumor radius. However, it assumes that the kidney is a perfect ellipsoid and the tumor is the perfect sphere, which is obviously not always the case. A score of 0 is a high complexity tumor where the tumor is superimposed on the center, and 1 is where the tumor is at the renal periphery. The contact surface area, or the CSS score, was proposed by Leslie and I.S. Gill in 2014. It needs a dedicated imaging software. It cannot be calculated clinically. And however, it has been seen that the CSS score of 20 centimeters square or above is associated with multiple operative variables and poorer outcomes. And now we come to the less used scores, the Mayo RCC probability, which predicts the difficulty in intraoperative perirenal fat dissection. Essentially, what it is the so-called sticky fat, which is used in partial nephrectomy, and the arterial-based complexity proposed by Spalaviero and Massimiliano et al. In 2015, which categorizes renal masses by the order of vessels that need to be dissected or transected during partial nephrectomy, with 1 being the distal vessels, the interlobular and arcuate arteries, and 3S being segmental arteries, or 3H being the arteries in close proximity to the renal hilum. The renal score is what we use most commonly. So let us see a few examples. These are low complexity tumors. As we can see in the tumor on the left, there is a tumor in the left kidney, which is small, far away from the collecting system, and nearly completely exophytic. And it gets a score of 4A. While in the other image, the tumor is on the posterior surface of the kidney, mostly endophytic, and relatively closer to the collecting system. So it gets a score of 5P. Here are some moderate complexity tumors. In the one on the left, we see that there is a hilar tumor where it is difficult to characterize it as anterior or posterior, which is why it gets a designation of X. And it is hilar, so it gets 2H, thus giving us 9XH as the score. And in the other tumor, again, it's a hilar tumor, however, anterior, but it is very close to the collecting system, so 7AH. And here we have a high complexity. We have 2 high complexity tumors. One is almost completely infiltrating, associated with the hilum, completely endophytic. So it gets a score of 11X, and the other one gets a score of 10P. Now let's come to the applications. What are the advantages of nephrometric scores? The renal, the Padua, and the spare correlate well with each other, and also correlate well with the achievement of the so-called trifecta, the warm ischemia time 25 minutes or less, negative surgical margins, and limiting complications to Clavin Dindo grade 3 or less, as well as pentafecta achievement of long-term outcomes of estimated GFR more than 90% of predicted, and no upgrading of CKD stage after 1 year of surgery. The C index and the CSA also strongly correlate with each other, and it has been seen that they are very good predictors of outcomes, especially the expected GFR after surgery. However, the nephrometric scores have certain limitations. The renal and the spare are relatively poor predictors of GFR preservation, and we must remember that they do not predict tumor complexity, which is associated with the lymph node spread, tumor thrombus, or extrarenal or other organ involvement. The C index and the CSA in the same way are relatively more difficult to calculate and have a longer learning curve. So now let us come to the applications. What the nephrometric scores help us in standardized reporting of tumor data and analyzing the tumor location. Most importantly, for the urological fraternity, they help us in surgical decision making. They very strongly associated with success of partial nephrectomy, which has been validated across multiple studies, especially the seminal studies by Dalkamp and Alora et al. They help us in prediction of perioperative and postoperative outcomes, the trifecta and pentafecta achievement, as we have already seen. Functional outcomes, the long-term reduction in GFR or CKD upgradation, and as well as oncological outcomes. They also help predict the efficacy and complications in focal therapy seen in large-scale studies by Schmidt and Klatt et al., as well as Chang and others. And now let us see what the take-home messages are. We need to remember, one, that there is no perfect nephrometric system. Each scoring system that we have seen has its own positives and negatives. Nephrometry is only part of the decision-making process. We need to remember that the decision for surgery includes patient factors, which are the age, comorbidities, the performance status, etc., as well as the renal function. Surgeon factors, which include the experience with the procedure, what technology we have on hand, and the volume of surgeries being performed, and tumor factors, which is where the nephrometry scores come into play. The renal and the spare are easy to calculate. The C index and CSA are relatively more difficult. The renal, spare, and C index have been extensively validated across many studies. And perhaps there is a need for incorporation of the renal or spare scores with the C index and CSA, which may give us a score which is even better for the prediction of outcomes in partial nephrectomy. Thank you.
Thank you, Kunjan. That was a very crisp presentation, and you stuck to time. So, would Professor Vijay Kumar now come in with his comments and any questions? And would Sameer, who mentored Kunjan, does he have any questions to ask?
Good evening, sir.
Good evening.
Yes, sorry to join late, sir. It was a nice presentation, actually very to the point, and the messages are very clear. Only point I just want to tell, its clinical application is still not clear, and very much recommended outcome or recommendation for specific clinical use is not clear till now. Yes. So since there are a lot of many number of nephrometry scores are there, I think there should be one validated nephrometry score for our clinical use. That's the only point I just want to know, because I am still confused which nephrometry score is really better and in which situation.
So, urologists most commonly use the renal and the Padua or the spare score now, which has been seen to, especially what we most commonly we use them for informing us whether we will be able to achieve a nephron sparing surgery successfully or not. In this, it has been seen that the renal, the spare, as well as the C index and CSA have good correlation with outcomes. Most commonly, what we use in our institute, we use the renal score.
Oh, that is a commonly used score. What is almost adopted in all the centers.
Yes.
But my concern was just to know, is there any specific still, because there are a lot of scores and there are a lot of confusion. One is going towards the anatomy, one is going for functionality study, one is going for the feasibility of the surgery, another is for outcome measurement, and another is to know whether there will be chances of complications, another is to know whether EGFR. So there are multiple parameters and multiple type of scoring. So I just wish if there would be only one or maybe specific type of nephrometry score that may come up in future, so that all the aspects are to be clearly answered. That's
a similar score, which yes.
Okay.
Just a minute.
Yeah, let Professor.
Thank Dr. Kunjan for his nice presentation, and also Dr. Swain for mentoring him. The basic issue is that the partial nephrectomy is gradually developing. I still remember in 2007, There was a debate, partial nephrectomy versus radical nephrectomy for RCC, and I consulted Dr. Kalyan Sarkar at Rajgir conference. He was speaking for the partial nephrectomy. I was going against. Things are, a lot of water has flown through the years over the years, and things are changing. The optics, the technology has improved. And with coming years, naturally, there will be fineness, improvement in the equipments. Robotic has make a difference, palpable difference. And it is the dissection has become more clearer. The vision has improved. I think things will improve. And with gradually picking up standardization for these scores will also be done. I think let us hope for that. Still, there are so many confusions which will be cleared only with experience and time, I think. Do you agree, Dr. Sarkar?
Yes, I agree. And I think it has been an excellent presentation. And now let's move on to the next lecture. Would Dr. Noori please share his presentation? He's going to talk on focal therapy in renal cell carcinoma. He has been mentored in this presentation by Dr. Partha Pratim Das. So, Dr. Noori, please.
I think there is some problem with the presenter. Is the next presenter over there?
Any problems, Dr. Noori? Hello, can you hear us? Shall we move to the next presenter then?
I think
Dr. Ravikant. Hello.
Yes, sir.
Dr. Ravikant, yes. Please
Yes, sir.
share.
Good evening, sir.
Yes. And Dr. Ravikant, please introduce yourself. You are going to share your slides now, and you're going to give us a summary of the current clinical trials and recent developments in the management of locally advanced renal cell carcinoma. You have been mentored by Dr. Rajkumar Sharma, and I think he's also in the audience. So please share your presentation. This will be followed by Dr. Kurmi's presentation. Please get ready to share your presentation as well. And in the meantime, I would request our secretarial staff to please contact Dr. Noori and assist him in in his presentation later on.
Is my presentation visual, sir?
yeah.
Very much so. Please carry on.
Very good evening, sir. Myself, Dr. Ravikant Sinha, from doing my DNB from Paras Hospital, Patna. I would be speaking on current clinical trials and recent development in the management of locally advanced renal cell carcinoma. First of all, we'll all know the which is categorized in the locally advanced renal cell carcinoma. To define it involves the inferior vena cava, adjacent organ involvement like T4, staging, involvement of the retroperitoneal lymph node, and local recurrence after radical surgery. The actual triad of the renal cell carcinoma, that is hematuria, flank pain, and flank mass, is well appreciated in locally advanced renal cell carcinoma. The 5-year survival rate differs with localized cases. 92% is for regional aspirate, it is 68%, and for distant aspirate, it is 12%. There are different staging systems, scoring system like TNM, recurrent risk scoring, SSI, GN, and UCLA. And the patient performance is being scored by Karnofsky and ECOG performance status. To move ahead for the clinical trial, we must know the tumor biology and its clinical implication. Among the biological characteristic, the tumor has the expression of the activity of multi-drug resistant, which contributes to chemorefractory nature of the renal cell carcinoma. Another is immunobiology and immune tolerance, which shows responsiveness to the high dose of interleukin-2 and other immune checkpoint inhibitors like PD-1, PD-L1 or CTLA4. There is angiogenesis and targeted pathway that shows the response rate to the targeted therapy and dependence on the mTOR pathway that shows the response to the temsirolimus and everolimus. For the molecular basis for the targeted approach, mainly dependent on the HIF factor alpha. It's when its concentration increases in the cell, it induces the angiogenesis by inducing the vascular endothelial growth factor PDGF and tumor growth factor that leads to the development of more development of the tumor cells. Mainly regulated by VHLA complex. When it got disrupted, the degradation of HIF decreases and the accumulation of HIF increases. Coming to the mechanism of action of the immune checkpoint inhibitor, mainly the antigen presenting cell expresses there is MSC complex and B7 that interact with the T cell, TCR receptor, CD28 receptor, and CTLA4 receptor. And another receptor on the tumor cell that is PD-L1, that is programmed death ligand L1 that interacts with the PD-1 receptor of the T cell that results into the T cell activation. And when we treat with the PD-1 or PD-L1 or CTLA4 inhibitor that blocks that T cell inactivation and further activates the T cell that is responsible for the damage of the tumor cells. Coming to the treatment of locally advanced renal cell carcinoma, when it involves the IVC, mainly it is reported in 4 to 10% of cases. When we come to know about the IVC tumor thrombus, they present with the features of lower extremity edema, isolated right-sided varicocele, the dilated superficial abdominal vein, proteinuria, pulmonary embolism, or non-function of the involved kidney. Basically, it is categorized in level 1, level 2, 3, and 4, well depicted in the picture. And their management is also differed by the their level. That is, level 1 is well managed by just using the Satinsky clamp. Level 2 managed by sequential clamping of the distal IVC, contrarenal renal vein, and the proximal IVC with the mobilization of IVC. But level 3 needs more mobilization of the IVC as well as the liver mobilization to get control of the tumor. There comes the Bland's thrombus. That in the recent study, it has said that Bland thrombus may be left in situ when resection places the patient at the undue risk of the complication. And there is evidence and recommendation by EU guideline that strongly recommend the removal of renal tumor and thrombus in case of venous involvement in non-metastatic disease. Next is the locally invasive RCC, that is stage T4, that when it involves the adjacent organ. Their main aim of the therapy is to completely excise the tumor, including the resection of the involved organ. And some studies have well considered the neoadjuvant systemic therapy for the patient with potentially unresectable RCC, because even with the aggressive surgical approach, the prognosis remains very poor and we cannot give the R0 resection. There are few factors which favors the nodal involvement for the locally invasive RCC, like large tumor more than 10 centimeter, higher grade and higher clinical stage, sarcomatoid features, and histological tumor necrosis that clearly depicts the locally involvement of the regional lymph node. Here comes the role of cytoreductive nephrectomy. It was the standard of care since early cytokine era, indicating prolonged survival benefit with upfront nephrectomy. It was just to give a palliative intent to the patient with intractable pain, hematuria, or constitutional symptoms, or a variety of paraneoplastic manifestations such as hypercalcemia, erythrocytosis, and secondary thrombocytosis or hypertension. Many studies supported this practice because it has been said that there is a spontaneous regression of the metastatic lesion after nephrectomy, or there is large tumor burden that may inhibit the T cell function, or there is inability of systemic agent like cytokine to induce the response in the primary renal tumor. There are certain trials like Carmina trials. This is an RCT trial investigating immediate cytoreductive nephrectomy followed by sunitinib or versus sunitinib alone. This trial concluded with the saying that the sunitinib alone was not inferior to the nephrectomy followed by sunitinib in metastatic RCC patient. Other is CERTIME trial. This was phase 3 trial in MRCC. This for the immediate versus deferred cytoreductive nephrectomy in patient receiving sunitinib. The trial failed to achieve its objective because of the poor accrual. Sunitinib alone was favored compared to cytoreductive nephrectomy, followed by sunitinib. There are other trials with the newer therapies that have shown cabozantinib as well as the combination therapy of nivolumab plus ipilimumab to be better first-line agent in the intermediate and the poor risk metastatic RCC patient. There comes the neoadjuvant and adjuvant therapy. Neoadjuvant adjuvant therapy basically deals with the immunogenic approaches. Earlier, it was dependent on a T and B cell mediated anti-tumor immunity, well treated with the interference and high doses of interleukin-2. This high dose of interleukin-2 shows the good result, but there was major limitation with the limited by the toxicity of its use, like vascular leak syndrome, hypotension, third space fluid retention, and respiratory compromise. There comes a targeted molecular agent that was aims to target the vascular endothelial growth factor receptor like bevacizumab, sorafenib, sunitinib, pazopanib, axintinib, and cabozantinib.
Yeah.
The median overall survival and the percentage of patients surviving 2 years treated in the era of targeted therapy, as per the IMDC risk group, shows the median overall survival with the favorable group was 43 months, and with the poor risk category, the median overall survival was 7.8 months. There are various immune checkpoint inhibitors like PD-1 inhibitor, nivolumab, pembrolizumab, CTLA-4 inhibitors, that is ipilimumab and tremelimumab, and PD-L1 inhibitor, that is etolizumab, durvalumab, and avelumab. Other is mTOR inhibitor and chemotherapy. The ongoing or recently completed clinical trials in the adjuvant treatment of the renal cell carcinoma. One is the targeted molecular agent. A trial is the ASSURE trial, that is adjuvant sorafenib or sunitinib for unfavorable renal cell carcinoma. This is one of the largest adjuvant trial comparing the sunitinib versus sorafenib versus placebo group. The result indicated that adjuvant therapy with sunitinib and sorafenib have no benefit of the overall survival at 6 years, and 45% of the patient in the treatment arm discontinued therapy because of toxicity, leading to the early discontinuation of the trial. Other is the PROTECT study. It included pazopanib versus placebo group. The primary endpoint was amended because of the toxicity with the pazopanib 800 milligram. That was remodeled to the pazopanib 600 milligram. But a subset of analysis of this study says that full dose therapy is associated with the improved disease-free survival with high dose of the pazopanib, that is 800 milligram. In ATLAS study, that includes the orally twice daily axintinib 5 milligram for a period of 3 years. The primary endpoint was disease-free survival. There was no significant difference in the disease-free survival or overall surveillance as per independent review committee. The ESTRAC study, it shows a benefit of sunitinib over placebo for disease-free survival, but there was no difference in the overall survival. But there was limitation by the grade 3 or 4 toxicity in 60% of patients receiving sunitinib, which translated into significant difference in their quality of life for the loss of appetite or diarrhea. Another is the SOURCE trial, Everest trial, and currently a lack of proven benefit of adjuvant therapy with VEGF and TKI for patients with high-risk renal cell carcinoma after nephrectomy. There are certain trials still in the process conducting with the immune checkpoint inhibitor, except Keynote trial, which gave is the overall survival and disease-free survival in the treatment arm with the pembrolizumab 200 milligram thrice weekly for 17 cycles. This shows the better disease-free survival at 24 months and overall survival at 24 months in respect to their placebo therapy. Coming to the Prosper RCC trial, it was a phase 3 randomized study comparing the perioperative nivolumab versus observation in the patient with localized renal cell carcinoma undergoing nephrectomy. So, the estimated study completion was given to 2022, but its final result has yet to publish. Other trials were the effect trial for sunitinib in the continuous therapy versus the uninterrupted treatment with the dosing schedule of 50 milligram per day, 4 weeks, and thereafter 2 weeks without treatment. And in uninterrupted group, there was the 37.5 milligram per day in a patient with clear cell metastatic RCC. There was no significant difference in the overall survival was seen. In contrast trial, comparing the pazopanib with sunitinib, this trial established the pazopanib as an alternative to sunitinib, and the quality of life was better with the pazopanib. In PCS trial, patient preferred pazopanib to sunitinib due to the symptomatic toxicity, and there is trial going on with the cabozantinib, that is cabozantinib RCT trial for intermediate and poor risk patient favoring the cabozantinib for the risk relatively.
We are running out of time now, so please conclude.
So about to complete. In AXIS trial, axitinib was compared with the sorafenib in the patient who had previously failed cytokine treatment or the targeted agent. Axitinib was associated with the greater progression-free survival than sorafenib. And final analysis of the overall survival showed no significant difference between the axitinib and sorafenib. In the mature trials, cabozantinib showed delayed the progression-free survival compared to the everolimus in targeted therapy. And the median overall survival was better with the cabozantinib than with the targeted therapy. So finally, the recommendation for the neoadjuvant and adjuvant therapy, it showed a strong recommendation for without adjuvant therapy. And so the studies, various studies shows that the use of the adjuvant or neoadjuvant therapy has not shown the overall survival or disease-free survival. Thank you, sir.
Thank you. You've presented a lot of data in a very short time. Thank you for your presentation, but there was a little deviation from actually the main purpose of this presentation. So if we are looking at it as answering an exam question, then the objective was to just probably, if you had just concentrated on what you presented at the end, that the recent trials, that adjuvant therapy after resection or maybe R0 resection of a locally advanced renal cell carcinoma, that there is emerging role of pembrolizumab and maybe concentrating on the S-track trial, and that which showed a little benefit, and the other trials which did not show a lot of benefit. I think that was the object of this presentation. But I think we've got Dr. Rajkumar Sharma and the audience. Yes, also we've got our uro-oncology resource person, Dr. Arun Jindal, and Dr. Kanishka Sarkar, if they have any comment.
Yes, actually the presentation was very exhaustive, and because lots of trials are going on, and still even not a single trial has come to the conclusion that adjuvant can be advocated after doing R0 resection in the locally advanced carcinoma. So basically, in a nutshell, if we summarize the locally advanced carcinoma cases, the treatment for the IVC involvement, level 1 or level 2, we can remove in our OT. Level 3 and level 4 will need expert and higher center referral as well as cardiopulmonary bypass. Need of cardiovascular surgery. There is lots of disturbance. So IVC level 1 and 2, you can manage. And for the 3 and 4, you need expert team. Then coming to lymph node involvement, this is also locally advanced disease. It has been seen that its lymph node involvement and lymph node resection is not advocated today during surgery. It has importance in staging, but there is no definitive therapeutic role in lymph node dissection. The third locally advanced carcinoma is local invasion to the surrounding structure like colon or adrenal. So here you can en bloc resect the colon, spleen, adrenal, and the local surrounding structure. It has a definitive role in cure if you achieve R0 resection. And regarding Kalyan sir already has told, the adjuvant and neoadjuvant still trials are going on. And let's see in near future, maybe some drug will come and we can use in our clinical setting, in our setting. Thank you, sir.
Thank you. I think that was an excellent summary of a difficult subject. And when you get an exam question like that, you've just got to put in the key points, which Dr. Sharma, very nicely summarized. So, any other comment from anyone?
Sir, can I make a very clinical comment?
Yes, please.
Sir, for my junior surgical colleagues, I would advise them for these locally advanced renal cell carcinomas to get an MRI of the local area done before surgery, or discuss the radiology properly with the radiological consultant before going on for surgery, firstly. And secondly, it's to remember, sir, that drugs like sunitinib and axitinib are often very toxic drugs. They cause a lot of hand-foot syndrome. They cause a lot of diarrhea and rashes. So in the community, there is a tendency of, okay, after operating, let's give us some adjuvant treatment, but they should definitely be used with caution. And we generally do not recommend any form of adjuvant TKIs for locally advanced renal cell carcinomas after cytoreductive nephrectomy.
Right. I think we'll move on if Professor Vijay Kumar has a comment to make. So shall we move on to the next presentation then? Who is ready? Will the organizers tell us?
Hey, Dr. Nuri.
Hello.
Okay. Yes. So Dr. Nuri is going to present on focal therapy for renal cell carcinoma.
Hello, sir. Am I audible, sir?
Yes, you are. So please share your presentation, or let his presentation be shared.
Yes, sir.
So, Dr. Nuri, are you able to share?
Yes.
Okay.
Hello.
Dr. Partha Pratim Das has mentored him for this presentation.
Sir, am I audible, sir? Hello?
Yes, you are. Yes, you are. Please carry on.
Yes, my screen is.
Yes, your screen is visible. Please carry on.
Visible, sir? My screen is visible, sir?
Yes, it is.
Good evening, respected teachers and my colleagues. Today, my topic is on focal therapy in renal cell carcinoma. According to AUA guideline 2017, it is a valid alternative treatment.
Dr. Nuri, please introduce yourself first.
Humors, or for those with substantial comorbidity. Nephron sparing surgery is standard of care.
Dr. Nuri, please introduce yourself first.
Sir, my name is Dr. Mohammad Tagdish Nuri, sir. I am PDT Urology, third year in SSKM hospital, sir.
Very good. Carry on.
Sir, according to AU guideline 2017, focal ability therapy is valid alternative treatment for patients with clinical T1A tumor or for those with substantial comorbidity. Nephron sparing surgery is standard of care. The indication of focal therapy are small renal tumor who either poor surgical candidate or at risk of renal insufficiency, including solitary kidney status or bilateral renal tumor or any hereditary syndrome like VHL. Second indication, recurrence after nephron sparing surgery or ablation after ablation therapy. Advantage in comparison to nephron sparing surgery are it is better or comparable post of renal function. There is less complications in focal therapy. Technically, it is technically easier. Early post of recovery, less time consuming, and it can be developed via open lab or percutaneous approaches. Types of focal therapies are cryoablation, radio frequency ablation, and newer technique like high frequency focused ultrasonography, microwave ablation, irreversible electroporation, radiation, targeted embolization, and ablation. Now, first come to the cryoablation. The history in mid 1980, Dr. James Arnold obtained temperature minus 18 to minus
Dr.
24.
Nuri, your slide is not moving.
No.
Your slide is
sir.
fixed. No, it's fixed.
Just 1 minute, sir.
Yeah.
Moving, sir?
Yeah, now it's moving. Move ahead. Go ahead.
Now, sir?
Yeah.
Okay, sir. Thank you, sir. Now, first come to the cryoablation. In history, mid 1980, Dr. James Arnold obtained temperature minus 18 to minus 24 degree by using ice and salt to treat breast and cervical and skin cancer. In 1963, Coopers and Lee developed first modern cryoprobe using pressurized liquid nitrogen at achieved minus 196 degree. In 1999, Riva Kessel et al. Developed argon-based probes. It achieved a temperature of minus 185.7 degree by rapid expansion of high pressure inert gas. Example of the argon-based system are cryoid and cryoker. For renal tumor ablation, in cryoablation, the preferred target temperature is at or below minus 40 degree. It performed under real-time imaging with the treatment area approximately 5 to 10 millimeter beyond the zone of tumor. Double freeze throw cycle is used in the cryoablation. Each cycle should be 8 to 10 minutes is the standard of care. The mechanism of cryoablation during rapid freezing, the formation of ice crystal inside the cell and also outside the cell, and also the it injured the endothelium of blood vessel. Due to intracellular ice crystal formation, it caused mechanical trauma to plasma membrane and organelles, which cause direct cellular injury and ultimately coagulative necrosis. During extracellular crystal formation, it was depletion of extracellular water, which caused dehydration of the cells, and due to dehydration, membrane rupture and cell damage occurs. And ultimately, coagulative necrosis, cellular death, and apoptosis fibrosis. During throwing, extracellular osmolarity decrease as ice melts. It causes influx of water into the cell, which cause cell edema, disruption of cell membrane, and ultimately cause cell death and necrosis. Throwing may be active type or passive type. In active type, helium gas is forced through the probes, which creates a warming effect, and secondary warming effect secondary to Joule-Thomson principle. Joule-Thomson principle. So, and the second throwing is throwing may be passive type. In passive, ice ball melting without any interventions. The second modality is radio frequency ablation. It uses radio frequency energy to heat the tissue to the point of cellular death. Mechanism of radio frequency ablation are the radio frequency probe are passed into the tumor. It uses monopolar AC current of 450 to 1200 kilohertz. It causes vibration of ions into the tissue. inside the tissue, and due to
Slides not moving.
sorry, sir. Now, sir,
Okay,
it is
okay.
moving.
Are we on the right slide now?
Moving, sir. Is it
Now
moving,
it's
sir?
okay. Now it's okay.
Yeah.
Due to vibration of ions inside the tissue, it causes molecular friction and heat production, and ultimately cellular death. Radio frequency ablation therapy multiple equipments like monitoring systems. Monitoring systems are maybe temperature based or impedance based, and the tip of the probe it monitor the temperature of the. Yes, sir.
Dr. Nuri, I think there's a little problem. Are you on? You are showing slide number 8 now. Are you talking to that slide?
Just 1 minute, sir. Sir, I'm talking about 10th.
Yeah. This we can see.
Can you just make it a slideshow rather than this thing? You can just enlarge it. There's a button on the right side.
Yeah.
Yes, sir. I am sharing mode, sir. But
not working.
Not working, sir. This is 10th slide, sir. RFA radio frequency ablation equipment, sir.
Okay, carry on.
Yes, sir. First is monitoring system, which is either temperature based or impedance based, sir. Second is probes. Probes may be a single electrode monopolar probes. Another types is leveling insulated monopolar probes with 12 deployable tines by Boston Scientific. Third one is starburst shaped RETA device with 5 to 9 electrical tines by Angiodynamics, and another type is covident, which is cooled internally with chilled saline to prevent charring. Next is wet and dry radio frequency ablation. Is it seen, sir? This slide is seen?
No.
Now,
Yes.
sir?
Now,
you
yes.
Have, you have to click on the left-sided slide, like slide 11, 12. Then it will come in mains.
Okay, sir. Okay, sir. Now come to the wet and dry radio frequency ablation. In dry radio frequency ablation, there is more charring effect, which called increased resistance to current, which limit the size of ablation. Second is wet radio frequency ablation, which there is constant delivery of saline into the tissue, which decrease the temperature of the tip of probe, and which cause less charring and large zone ablation. But disadvantage of this wet radio frequency ablation is over treatment. Next equipment as it may be monopolar or bipolar, sir. But in bipolar, high temperature produced using during the treatment, large area of coagulation necrosis occurs, but there is this elliptical area of coagulation of necrosis with bipolar probes. So bipolar probe are not preferred nowadays. Treatment temperature in radio frequency ablation in temperature based system, that target temperature should be 90 to 105 degree Celsius, but in impedance based system we started at 40 to 80 watt and increase at 10 watt per minute to maximum of 130 to 200 watt until an impedance of 200 to 500 ohms reached. But in radio frequency there is heat sink phenomenon occur commonly. So due to the adjacent large vessels, the thermal energy dispersed inside the vessels, so it results in treatment failure. Selective embolization may help to prevent this. During intra-op treatment monitoring during radio frequency ablation, it mainly depends on measurement of electrical impedance and temperature of the tip of the probe. The successful ablation by radio frequency ablation depends on precise probe placement. Currently, no radiographic method to evaluate the zone of treatment. Only probe placement can be visualized radiographically. The surgical technique for radio frequency ablation and cryoablation. The anesthesia mainly used during the ablative therapy are conscious sedation with local anesthesia. It is less timing, but general anesthesia can be used. It is more accurate target due to more control over respiration. The surgical techniques may be lap or percutaneous. Laparoscopically, transperitoneal approach or retroperitoneal can be used. and percutaneously CT guided percutaneous approach is used. It is most preferred approach. The ideal for laparoscopic procedures are the tumor which are anteriorly placed or adjacent to bowel. Next one, the tumor close to the collecting system and without suitable imaging. Ideal for percutaneous ablation are the posterior tumors, laterally placed tumor, or tumor which is 0.5 centimeter away from the adjacent PCS and 1 centimeter away from adjacent bowel. The treatment success and follow protocol after ablation. The radiographic cross-sectional imaging is the accepted measure for efficacy. Routine post-ablative biopsy is not recommended. Enhancement of lesion on follow-up CT or MRI should be considered as a recurrence, and biopsy or repeat ablation should be strongly considered. The recommended radiographic follow-up is CT or MRI with 3 to 6 months after ablation, and then annually for 5 years. Chest X-ray should be done annually for 5 years. The complication during the ablative therapy as major urological complication 4.9% and 6% with renal cryoablation and radiofrequency ablation respectively. Similarly, non-urological complications are 5% and 4.5% with cryoablation and radiofrequency ablation respectively. Mainly 5 to 6%, the 5 to 6% complications rate. The complications mainly are post-ablation syndrome. There is fever and pain, malaise, myalgia, probe insertion site pain. It is most common complication after ablative therapy. Then mild hematuria or throat colic pain, perinephric hematoma. But perinephric hematoma not occurs in during cryoablation. Thermal injury to the organs, hemorrhage may be needed. The hemorrhage may occur. It may needed angioembolization. Post-ablative infections may occur. Post-ablative infection occur mainly after 1 to 6 months. So before the procedure, preoperative antibiotics should be given. Oncological outcomes are outcomes and complications are similar in cryoablation and radiofrequency ablation. Overall survival is 75% to 85% at 5 years and 54% to 64% at 10 years with this focal therapy approach. A local recurrence free outcome in case of cryoablation and 90.6%. In case of radiofrequency ablation are 87%. No difference in metastatic free survival when comparing extraoperative surgery and thermal ablation. No difference in cancer-specific survival when comparing surgery and thermal ablation. Now come to newer technique like high intensity focused ultrasonography. In this approach, high intensity ultrasound of 3500 watt per centimeter square used with 20 kilohertz to 20 megahertz frequency. It produces heat in the tissue, and due to heat production, cavitation and microbial formation occurs, which cause destruction of tissue. Hypo in kidney is inferior to other ablative procedure. It should be considered investigational. More clinical data is needed. Next is irreversible electroporation. It is only non-thermal ablative method. It's single or multiple electrode generate electric field around the cell, which cause nanoscale pore in the cell membrane, which increases permeability and cell death. The very limited clinical experience with renal tumor and remains investigation. Next is microwave ablation. Subset of electromagnetic spectrum similar to radiofrequency ablation energy is used in medical use. Frequency is 900 megahertz to 2.4 gigahertz. It creates water ion oscillation in the tissue and frictional heat. Advantage over the other method is faster heating, no tissue tearing and desiccation, less susceptible to heat sink phenomenon, but limited clinical experience with this modality. Larger prospective study needed with longer follow-up needed to understand the optimal tumor characteristic. Next is radiation. Presently, its use should be considered experimental because there is no consensus for dose fractionation technique or appropriate criteria for imaging. Next is targeted embolization and ablation. Attempted to reduce heat sink phenomenon during to reduce the heat sink phenomenon during radiofrequency ablation. It remains experimental. Now come to the some guideline.
perform a percutaneous renal mass biopsy prior to and not concomitantly with thermoablation. When thermal ablation or active surveillance are offered, discuss with patient about the harms and benefit with regard to oncological outcomes and complications. Strong recommendation. Take home message is patient with a significant comorbidity, ablative therapy like cryoablation, radiofrequency ablation are considered viable alternative to extubative management of clinical T1A renal carcinoma. It is technically less challenging, inferior local tumor control, but with equivalent cancer specific and overall survival as compared with partial nephrectomy and radical nephrectomy. Thank you, sir.
Thank you very much, Dr. Noori. Now, Dr. Das, you have mentored Dr. Noori in this presentation. Do you have any comments to make here?
Good evening, everybody. Actually, this is a new. We people are not worked or we have no experience about this. It's just a theoretical that we have all gathered about these things. So if someone has worked, done these things, they can tell it better. I mean, whatever is expressed, that is all I gathered from the text and all. As because this is not done in our setup, or I have no experience, I cannot give more information about this.
I think Dr. Jindal has been working in a center of excellence in Kolkata.
Yeah, Torunda can say about his experience about
we have a little scattered, isolated experiences, but radio frequency ablation is very much available in the city. It's offered to various tumors, including renal tumors. And but let's hear from Dr. Jindal and perhaps Dr. Kanishka Sarkar about their experiences.
Thank you, sir. So yes, we have two modalities now available at Calcutta. RFA was available from a very long time, but now even the microwave therapy is available. RN Tagore is presently doing the microwave therapy there. So the RFA does have its own merits and demerits. So RFA, because of its ability to tackle tumors approximately of 3.5 centimeters in size, is very widely used. Anything beyond that, it's generally used with along with an angioembolization. So they tend to angioembolize the tumor first, shrink the tumor, and then they do a RFAs. Again, cryo, we do not have much information about the cryo, but yes, PGI people do cryo for certain tumors, PGI Chandigarh, and they have found good results. So three most common modalities which are used are RFA, cryo, and microwave thermal therapy, and results are decent. So I would, as a surgeon, contradict that the results are as good as partials, but yes, I mean the results are decent. So we maintain that anybody who's less than 45 or 50 years of age, we offer them partial as the primary modality. And if the person is elderly or we cannot operate him upon, then these options are given.
Yes, I agree. These are viable options.
Sir, one thing I would like to ask is Tarunda has any experience of doing surgery after cryo or?
Yes, so after an RFA, we have done a partial nephrectomy. So we planned for a partial nephrectomy, but the sticky fat situation was terrible. So we ended up doing a nephrectomy. So yes, we have had a recurrence. I mean, recurrence not in the site which was RFA. So this was in the same kidney, but the pole was different. So this was a lower polar tumor and had a recurrence in the upper pole. So we planned for a partial, but we could not do it because of dense fibrosis there. So we ended up doing it.
It is very difficult to.
It is very difficult.
I don't have any experience, but I have heard.
No, it is very difficult. It's basically everything sticks there, so it's very difficult.
So that's why it is this modality of treatment is considered for those patients who are not surgically amenable. I mean, surgically fit.
Absolutely.
So there is no scope for post RFA or post cryo surgery.
Correct.
I mean, if a person is not fit for surgery, then there is no scope for doing surgery after doing RFA or cryo.
No, the literature says that you can do it, but our experience with just one case was terrible. So I would not like to do it ever again.
I think the point here, the point to make here is that of the two modalities, cryo is very expensive equipment, so not widely available. But there are advantages in the cryo that the ice ball, you can destroy the tissue much more efficaciously because 3 millimeter, an ice ball is created. It can be followed radiologically, and if you sort of target about 1 centimeter beyond the lesion, if the ice ball extends, then it works. So it's more precise cryoablation. Now, here in Kolkata and in India, RFA is more frequently used. But the trouble is that there are two limitations. The RFA, difficult to use in anterior tumors. The colon has to be hydrodissected away to apply to use RFA. This is what the interventional radiologists tell us. That is number one. And secondly,
one thing I would like to know, routinely you do biopsy for these patients because after
100%, 100%.
100%.
100%.
After you will not get anything now. That's why biopsy is a must.
So, so the other thing about this RFA procedure is that if there is follow-up is important, and if there are radiologists then predict actually if there's a recurrence, and if there's a recurrence, then these procedures may have to be repeated, and so there are limitations, but so the definite applications in elderly patients with limited renal reserve and who are unfit for surgery. So. It is very much there actually, and it's in the current guidelines actually for T1A tumors in patients who are not fit for partial nephrectomy. So we had the liberty of a little discussion here because I think our fourth speaker is not available today for whatever reason. We'll see if we can get slot him in again tomorrow. So if Professor Vijay Kumar has any comments to make. Otherwise, we'll move on to the next session, the next set of presentations. Dr. Kumar? Okay. I think let us proceed then to the next session, and there's a presentation from these are.
Let us move ahead.
Yeah, let us move. Yeah. So we'll go on to this operative surgery session, and I think our first presentation is by Dr. Partha Pratim Das, and essentially there are 4 presentations. One is step-by-step open radical nephrectomy to be presented by Dr. Partha Pratim Das, and then surgery for large locally advanced renal tumor, including surgical management of cable thrombus by Dr. Tarun Jindal. And then laparoscopic partial nephrectomy step-by-step, small renal mass by Dr. Rajkumar Sharma, and complex renal mass by Dr. Samir Swine. So maybe now request Dr. Partha Pratim Das to present, please.
Please share my presentation. I have given in the WhatsApp group.
Yeah.
Hello.
Ruma? Yeah. No, this is not the one, is it? Ruma, it's in the WhatsApp group.
Open radical nephrectomy.
Open radical nephrectomy.
How can you move it?
Yeah. I think Ruma will have to move it, or I don't know who's handling it, Ruma or Nirmanda.
Myself, sir. Nirmala is not here.
Okay. Previous slide. Okay. I am starting from here. I have just tried to make it theoretical as well as practical. So first of all, the anesthesia is general anesthesia. and the second is the patient position. And now the position of the patient, we operate here. You can see the patient. We operate in supine position. We just keep one roll of sheet, bed sheet. In the here is a right-sided tumor, so we put it in the right hypochondrial region. As usual, in the left side in the left hypochondrial, just to elevate the flank. And the patient is hyperextended to accentuate the line of incision. Just in this manner, and the parietal capillation is done. So patient is in supine, put a roll of cotton or a roll of bed sheet in the flank region. Now the incision is subcostal. Start from the xiphisternum, just 2 finger to the from the tip of the 11th rib or 12th rib on the ipsilateral side, 2 finger breadth below the costal margin, and it is extended medially up to the xiphisternum. Now here is a catch, that is we just extend the incision below so that it is the tumor we can approach posteriorly also. That's why we keep a roll so that the right side, the side of the tumor side is extended, a bit hyperextended, so that we can go below. So the tumor, you can see the incision is curved below. Now next slide. Now still the incision is carried down to divide the anterior rectus fascia, external and internal oblique fascia, and muscles. Now step by step, then we open the transversus abdominis are split, rectus muscle and posterior rectus sheath are divided by placing straight clamp underneath. Peritoneal cavity is entered by tenting up the, this is the as usual procedure. Now self-rotating retractor is after examining the abdomen, just to see whether there is any ascites, palpate the liver, and metastasis. Then we actually here it is, even the self-rotating detector is not placed now. We actually move the colon first, after that we place the detector. Anyway, next slide. Now you can see the posterior peritoneum lateral to the colon is incised, and on the left side it is the descending colon, on the right side this is the ascending colon. Along the what light of told, these are lifted medially. Now here is a very important step here, because the two fat plane is to be you have to enter the two in between the two fat planes. The character of the fats are very important, and also the avascular plane, that is important. If you go the right plane, there will be no blood vessel, I mean minimal blood vessel, and we reflect it up to the medially, and so in case of right-sided tumor, we go up to the IVC, and in case of left-sided tumor, we go up to the aorta. So after this colon mobilization, we detector and try to set the highlight. On the left side, the laryngeal ligament incised to mobilize the spleen Actually, this is written in the book, but in dissection, laryngeal ligament incision is not always required, but sometimes you have to size it. And in case of same is a hepatic flexure of the colon is mobilized on the right side. Now, in our patient, which I am presenting, so it was a left-sided tumor. So we moved it up to the aorta, and then next slide. Now we identified the ureter, and the gonadal vein is ligated and divided routinely left side. Now here is the now we start dissecting the hilum. Our ideas, there is some different approaches. Hilum first, sometimes you have to go behind, but we usually do hilum first method. Now here is a what we follow is the gonadal vein. We first ligate the gonadal vein, and it is divided. Now we dissect the renal vein and take a look of the renal vein, and we try to move it upwards. Now here there are lumbar veins which prevents the rolling of the renal vein. So you should be very cautious during this procedure so that the lumbar veins are not torn. To find it, ligate it. Now on the plane between okay. Now on the right side, cauterization of the duodenum is essential, and we cauterize the duodenum, and after that the connection, the junction of right renal vein and right renal vein and IVC becomes clear after cauterization. Then we in the right side, then we dissect in between the IVC and the ureter. Now, in case of left, same aorta and the ureter. The plane you have to go up to the psoas major. Now, after dissecting, blunt and sharp dissection, mostly blunt dissection, we make a plane in between. In case of left side, between aorta and the ureter, and on right side between ureter and the IVC, just a window up to the psoas major. So after this window is done, then you try to go behind the renal vein. Ureter, sometimes it is required. Ureter can ligate after doing the nephrectomy. And now the ureter will be ligated. Now mobilization and upward displacement of the lower pole of the kidney. When we dissect, mobilize the kidney, the lower pole, and stretch it, then you can find the renal vein and the renal artery becomes taut. So you try to go behind the renal vein and dissect slowly to get the renal artery. Now sometimes it happens that if you don't get the renal artery just below the below and behind the renal vein, sometimes it is a bit above the renal vein. So in case of left-sided tumor, you have to ligate the adrenal vein, and you have to dissect the adrenal vein and then ligate it, and after that you pull the renal vein below, and then you will get the renal artery there. And in case of right, there is no structure there, so you just like the lower window, you make a superior window just in between the upper pole and the IVC, and you can, with making these two windows, you can easily palpate or ground the artery. Now, on the right side, ureter maybe like the next slide. Dissection is carried out separately along the vena cava on the right, and the right renal vein is identified exiting from the IVC encircled by the clamp. suture. Right renal artery is dissected free and cleaned for a distance of 2 centimeters, I think. Then it is encircled by right angle clamp silk. Right renal artery is divided, right? And now, after ligating the right renal artery, actually, what we do is we ligate the artery, and after that, we ligate the vein, because all know that if you ligate the vein first, it will cause fusion. So we first artery is dissected and ligated, and after that renal vein. Here is a point that make sure before ligating the renal vein that no supernumerary renal artery is there. So our common practice is you dissect the whole hilum, and after that you will find that the whole kidney is moving over the renal vein. But don't dissect the upper pole, because if you dissect all the side of the kidney and attached with the vein, there is high chance that the vein will get torn. So we usually do the lower hilum first. After that, lower polar dissection. Upper polar dissection is done last. So it is our approach. Right renal vein is divided, and after that we dissect the upper polar last. Now, in case of if the tumor is lower polar or mid polar, we actually don't remove that. We go in between the adrenal and the kidney capsule. And in case of upper polar tumor, we adrenal. Next slide. Now, courses over aorta. Left adrenal vein, left nodal vein from the left adrenal vein is present actually directed lumbar vein. Main renal vein is encircled by the number 0 silk. We always tie it with silk. Use silk here, and venous tributaries are ligated with 20 silk. Left renal vein is ligated and divided. Next slide. Left renal artery. Left renal artery is identified as the left renal ligated. Previous slide, please. Vein isolated pushes over aorta, left main renal vein circle. Same is left renal vein is ligated and divided. Okay, next. Left renal artery is identified. Now here I think artery is identified first. After that, left renal vein was divided. This presentation is not right. Mobilize aorta fascia posteriorly and superiorly using blunt and sharp dissection. On right side, short posteriorly located right renal vein can be present as it exits directly from the IVC, and if encountered, isolated, ligated, divided. Specimen is delivered and hemostasis is secured. This is abdominal drain. Next slide. Now closure as usual. Before closing, we see the hemostasis, and after that you will do the drain, and the roll of bed sheet that was given inside below the hypochondrium, it is removed. And it's layer repaired with layer by layer with number 1 liquid, and skin is closed. So this is the usually steps. Now here I want to make one just practical point that whenever during dissection, the best way to the hilar dissection is to make a furrow in between IVC and tumor on the right side, and IVC tumor kidney and the aorta on the left side. Make a furrow just below the renal vein up to the swastika. That is the main point. And after that, you try to go above and that will very easy. So that is the point I would like to mention during the highlight discussion.
Thank you very much. Thank you very much, Dr. Das. May I now request Dr. Tarun Jindal to carry on with his presentation?
Just a minute, Dr. Kalyan, Sarkar.
Yes, yes.
I just want to make 2 short comments.
Yes.
Am I permitted?
Yes, yes. I thought that we would have a discussion.
No. Just one thing. I just want to stress 2 points. We are not always that lucky that the two planes between the 2 layers of fat is discernible, especially in cases of locally advanced tumors where there are a lot of collaterals. In such situations, sometimes we used to do approach the renal artery first, as that is advocated in cases of dealing with renal trauma. The ligament of tree is dissected, the artery is controlled, and then the collaterals shrink to some extent, and then we move ahead with the nephrectomy. That is more practical with locally advanced tumors with lot of collaterals.
Yes, sir. I would like to. I would add here. In case of right-sided tumors, in 2 cases, we have dissected the aortic cable region in between interaortic region and ligated the artery there, and we found that very easy. There is no
life becomes comfortable after if you ligate the artery first.
Right.
But both the arteries are behind the vein, and it's very difficult to approach them if there are a lot of collaterals.
Right, sir.
So in that situation, you will have to move into the aortocaval groove for the right-sided renal artery and mobilize the left renal vein by ligating the gonadals and superior renal and the renal vein and adrenal vein, and then moving the renal vein up or down by hooking it up and ligating the left renal artery over there.
So
Thank you.
It is in case of right-sided tumor, interaortic dissection first is a very good procedure.
It helps. It makes your life comfortable.
But problem is on the left-sided tumor that the renal artery, left renal artery, is not very large. It is very small. So in case of left-sided tumor, the only approach becomes is the posterior approach, because anteriorly
then it will have to move the whole kidney ahead and go ahead with the
posterior
from behind. Posteriorly. That you have to find out the ways.
But
and
in case of right-sided tumor, interaortic dissection first is the best.
Yeah, it can be done. Okay, thank you.
Thank you.
Thank you.
So let's move on then. Tarun, would you please present?
Thank you so much, sir. Are my slides visible?
Yes, yes. Carry on.
Right. So the topic given for me today is the management of locally advanced RCC and the management of IVC thrombectomy. This is an important exam question, so I will just, let me just see whether my slides are moving or not. Yeah. So let's see. What constitutes a locally advanced kidney cancer? So by the TNM classification, anything which is stage T3 or T4 encompasses the category of a locally advanced kidney cancer. So we all know what T3 and T4 is. So T3 is divided into 3 categories: T3A, T3B, and T3C. So if the tumor extends into the renal vein or its segmental branches, or it goes into the PCS or into the perirenal or the sinus fat, but everything is limited to the aorta. So this is called a T3A. T3B, if the tumor extends into the vena cava, but it lies below the diaphragm. T3 if the tumor extends below the above the diaphragm or invades the wall of vena cava at any level. T4, that the tumor has gone beyond the Girotas fascia and it has involved organs like colon, spleen, liver, or the ipsilateral gland contiguously. So this all constitutes locally advanced tumors. It does not encompass tumors which are already metastatic. So because the locally advanced tumors have already been discussed in the previous presentation, so I have tweaked my slides. So I would deal with the renal cell carcinomas with the IVC involvement first. So RCCs are very unique that they tend to grow into the vasculature. So the tumors tend to go into the veins. They tend to involve the hilar structures. They tend to involve the pelvic ileal system. But this typical intraluminal growth of kidney cancers is a very peculiar phenomena which happens in the renal cell carcinomas. So along the circulation of the veins, so the blood which is drained out of the kidney and goes to the heart, along the flow of the blood, the tumor also tends to grow. In the clinical scenarios, we tend to see them very less frequently. So the percentage that tumors, the patient present with IVC thrombus is approximately 4 to 5%. In some series, they go up to 10%. It has been found that if you are able to treat or surgically treat these patients, almost 80% of these patients can be cured at least by the surgery if you are able to do a good radical nephrectomy and IVC thrombectomy. So what are the levels? So this classification, I would request all the exam going students to remember. This is the Nevis classification of the tumor thrombus. It is divided into 0 to 4. So level 0, if the tumor thrombus is there only in the renal vein. Level 1, if it goes into the IVC, but the calculation is from the renal vein ostium. So if the tumor extends less than 2 centimeters from the renal ostium into the IVC. Level 2, if it is more than 2 centimeters, but this has to be below the hepatic veins. Level 3, it goes at the level of the hepatic veins, or it is above the liver but below the diaphragm. Level 4 is supradiaphragmatic, or it goes up to the right atrium. So this is the pictographic representation. You can very well see that level 0 goes into the renal vein, level 1 less than 2 centimeters of IVC involvement, level 3 more than 2 centimeters. It can go up to the hepatic veins in level 3, and level 4 is supradiaphragmatic. So again, a very important exam question as well as the clinical question, which the examiner will certainly ask the exam going people is, when do you suspect IVC thrombus in a patient clinically? So the common pointers that the patient may harbor a IVC thrombus are lower limb edema, because the venous outflow obstruction is there. So that's why patients land up with lower extremity edemas. You might have varicoceles, more common on the left side, less common on the right side. If the right side varicocele is present, it can be because of the bland thrombus going into the lower part of the IVC. You may have dilated superficial abdominal veins because again the IVC is closed. So you need venous drainage from the lower part of the body and the collaterals open up. These patients tend to have more proteinuria. There might be a history of pulmonary embolism. There might be a right atrial mass, which was picked up on an echocardiography, which was done for some other purposes. And you might find that the creatinine levels are haywire in these patients, and generally because the kidney is basically non-functional. Now, how do we evaluate these patients? So we commonly do a CT scan, but for the thrombus per se, MRI may have an edge over the CT scan, though there are recent studies which are saying that even a multiplanar good CT scan is as good as an MR, but still you can answer both the modalities in your examination. So CT scan as well as MRIs are good for evaluation of the thrombus. MRI, if you are putting in a gadolinium contrast, then it is always very good, because it basically tells you whether the thrombus which you are dealing with is a tumor thrombus or it's a bland thrombus. MRI also edges over CT scan in telling you whether the venous wall is involved. So there can be pointers in the MRI which can tell that this person might need a venous wall patch if you are planning to take the thrombus out, or this patient might be harboring a bland thrombus which might require a resection of the IVC. So another very important practical point is that you should get the imaging done as close as possible to the date of surgery, because these patients already have a thrombus and they are also in a hypercoagulable state because of the tumor per se. So the surgical planning may change if you're planning according to an older CT scan. So always make it a point that you get a very recent CT or a very recent MRI in these patients. So this is the classical example of a patient having both the thrombi. So you can see that there is a tumor thrombi which is going up, and there is a bland thrombus which is going down into the IVC. Since this is an MRI with a gadolinium contrast enhancement, you can see that the tumor thrombus is enhancing in the nephrogram phase, while the bland thrombus is non-enhancing. Another investigation which can be of use in these patients is a PET CT scan. So if you do a PET CT scan, the bland thrombus will not glow, while the tumor thrombus will glow. So you can differentiate whether you're dealing with a bland thrombus or a tumor thrombus. Again, a very important exam question. Now, there is another old investigation which used to be done prior to the imaging modalities which were available. So when you have an MRI or a CT scan which are equivocal, or you cannot do an MRI, you cannot do a CT scan for some reasons, maybe a patient has an implant and has which is not MRI compatible. If the patient has a CT scan which is not clearly showing, or maybe a deranged function is there, so you cannot even get a CT scan. So then you can do an inferior venocavography. So this can again tell you whether you're dealing with a IVC thrombus, but it is a very invasive technique, and in the modern imaging era, you hardly ever require to go for this particular intervention. But yes, once we were students, there was an exam question which came in about inferior venocavography. Renal arteriography again is it's basically a diagnostic as well as therapeutic, so it is very rarely used. At times you might find that the tumor is vascularized and the tumor itself has arterialization. So in these cases, you can do a renal arteriography as a diagnostic procedure as well as a therapeutic procedure. So therapeutic, you can do an angioembolization preemptively. You can shrink the tumor thrombus, and then you can proceed with surgery. Again, if you angioembolize properly, the collaterals are also going to shrink. So once the collateral shrinks, it has been found that the amount of blood loss will also be less, because you have embolized the main renal artery. But it's a very technically demanding procedure, and not everybody would be comfortable, because as contradictory to the normal kidney anatomy, there are multiple renal arteries which basically supply the kidney. So if you embolize the main renal artery, the collateral supply will always be there. So the radiologist has to be extremely meticulous that he embolizes all the blood supply of the kidney, and only then you will have that effect. In these patients who have IVC thrombus, it is at times advisable to get a coronary angiogram also, because if you incidentally find some obstruction and if the patient is due for a bypass for the removal of the IVC thrombus, the coronary repairs can also be done simultaneously. This is an example of an arterialized thrombus. So in these particular cases, if you are going directly for surgery, you would land up with massive blood losses. So in these cases specifically, it is very much required that you angioembolize the artery so that the blood supply to the thrombus also goes off and the thrombus also shrinks. This is another intervention which is called transesophageal echocardiography. This is not done as an outpatient procedure, but it is done during the time of surgery, specifically in cases when the tumor is going into the atria or it is going supradiaphragmatic. It is also used to intraoperatively monitor whether the thrombus has migrated. So again, a very important exam question, that how would you monitor the patient if you are doing there's a high chance of venous embolization. So how do you identify whether the patient has got a venous angioembolization?
मीटिंग में आधा घंटा में फोन करते हैं.
So this is an important investigation which the anesthesia, the center in which we are operating, the anesthesia people have to be extremely cognizant about this technique. And it is also very useful to identify whether once you have removed the tumor out, at times you might not be able to see the tumor in the vein or the supradiaphragmatic IVC. So this particular intervention can tell you whether there is some amount of tumor remaining. Now, how do you manage? So majority of the tumors can be managed either by urologist alone or along with cardiothoracic surgeons or GI surgeons. Any thrombus which is extending below the liver can usually be managed by the urologist alone. You might be needing help of the hepatobiliary surgeon who can identify these short hepatic veins which are going to the caudate lobe, which at times need division if you're planning to mobilize the entire IVC. Or you might also need a liver surgeon to mobilize the entire liver if you're planning to go for a infradiaphragmatic IVC tumor thrombus removal. So again, a very important slide. So what are the surgical approaches? So there are multiple approaches described, and I believe all the exam going students should be aware of these approaches. So the incisions which are commonly used are either from the abdomen. So the most common incision which is used is called the chevron incision. Chevron is a complete bilateral subcostal incision. It gives a very beautiful exposure to the kidney, to the vasculature, to the IVC, to the aorta. So the entire area is open for your exploration. You can also give vertical incision, that is the vertical midline incision extending from the xiphisternum to the suprapubic area. So this particular incision is specifically used in patients who have a narrow subcostal angle, because if you are giving a chevron incision in patients who have a narrow subcostal angle, your exposure might not be appropriate. The other approaches are, you can go, if you are going for a supradiaphragmatic removal of the IVC thrombus, then you might need a full post-mortem incision, in the sense that the incision extends from the manubrium sterni and goes up to the pubis, and the entire abdomen and the chest is opened up. You can also give a midline chest incision, and along with that, for the abdomen, you can give a chevron incision. The third incision which is used is called the thoracoabdominal incision. This is again a very common incision which is asked in examination. So which intercostal space it extends from? So it is usually given from the 9th or the 10th intercostal space, and it goes to the midline, cuts the costal margin, and then it opens up to the abdomen. So you can extend that incision up to the umbilicus or even below that. For the right kidney, it depends. I mean, if there are too much of collaterals, I think this has already been discussed, that interaortocaval area is the best approach. So you basically tend to mobilize the DJ flexure, and up to the root of the entire mesentery is mobilized. You go up to the area where the interaortocaval groove is. You dissect into that area and identify the right renal artery, and you clamp it there. So once you have clamped the right renal artery, the collaterals will shrink, and then you can go up to for the colon mobilization. If you are going for a colon mobilization upfront in a patient who has too many collaterals, I think it will definitely lead to a major blood loss. So the best approach will be mobilize the root of the mesentery, go to the interaortocaval groove and identify the artery and clamp it there. If you're going on the left side, then the scenario is slightly different, because the artery is behind the vein, and at times if you have a lot of collaterals, it is very difficult to reach the artery. But again, you should mobilize the colon, mobilize the splenocholic ligament, mobilize the renodiaphragmatic ligament. The most important area, because these masses are huge once they've gone into the left renal vein and up to the IVC. So your mobilization and the identification of the renal hilum structures are extremely important, because there have been instances when the superior mesenteric artery, which goes just above the renal vein, is at times mistakenly identified to be going into the kidney, and you clamp it. So that can be a very major catastrophe. So always be very careful if you are doing a IVC thrombectomy specifically on the left side about the superior mesenteric artery. You tend to mobilize the kidney outside the gyrotras fascia, and you go to the ureters, identify the ureters, and at the end of it, you go to the hilum. Now, how do we approach the thrombus? Level 1 thrombus is slightly easier amongst all the thrombuses. So you can mobilize the IVC. If you don't want to mobilize the IVC, because level 1 is going up to less than 2 centimeters into the IVC, you can just use a Setinsky clamp as a cross clamp, and you can clamp the part of the IVC, give an incision over the renal ostium, or where the junction of the renal vein with the IVC is, extract the tumor out and repair that. The other approach is that if you want to do a formal mobilization of the IVC, you can again do that. So go into the interaortocaval groove, ligate the artery, identify the left renal vein, mobilize the IVC. If you want to minimize the blood loss, you can clamp the lumbar veins at this particular juncture. So mobilize the IVC below the right renal vein, mobilize the left renal vein, and mobilize the area of the IVC above the thrombus, so that you can have the good control of IVC if you want to control it. So this is the diagram which basically shows that how you give an incision. So this is again a very important exam question, that where do you incise? So the incision is a circular incision which is given at the junction of the renal vein to the IVC. So this, if you have too much on the IVC, you might compromise the lumen of the IVC. And if you have compromised more than 50% of the lumen of the IVC, if you are by inadvertent incision on the IVC, you would the patient would land up with venous congestion of the lower limb. So it is always advisable that the incision has to be given at the level of the ostium of the renal vein. So you incise, take the tumor out, you can flush, and then you can repair the IVC. So if you're going for the level 2 thrombus, so again, it is very good to have a transesophageal echocardiography. These tumors are slightly big tumors. So if you want to put up IVC filters, I mean, these are the cases in which you can consider putting preoperative IVC filters so that the embolizations do not happen. The approach depends upon the tumor, depends upon the patient habitus, but the most common incision which is used is the chevron incision. In this, you mandatorily have a control of the IVC, and be very cognizant that you are not too much mobilizing the thrombus. So if you are touching the thrombus too much or mobilizing the thrombus too much, then there is a practical risk that the thrombus might break and the patient might land up with a pulmonary embolism. So as we have already discussed, so you basically clamp the renal vein, left renal vein, the IVC, and then take the tumor out. The incision remains the same. So the sequence of clamping is again very important. Again, a very important Viva question. So you tend to clamp the infrarenal vein IVC first, then you clamp the left renal vein, and then you clamp the suprarenal IVC. And how do you unclamp? The pattern is again the same. So you unclamp the suprarenal IVC first, then the left renal vein, and then the infrarenal IVC, because the major amount of gush of blood will happen from the infrarenal IVC. Another important question which I would like to highlight at this particular juncture is that what will happen to the kidney if you're clamping the left renal vein? Why does the kidney gets into not ischemia per se but congestion? So the answer is that the left kidney has the gonadal vein and the adrenal vein, by the virtue of which the venous circulation is maintained in the left kidney. So this is the image, how you do the clamping and how do you remove the thrombus. Another important point at this particular juncture, which I would like to highlight, is that intraoperative ultrasound, if it is available, it is a very, very important modality, so that you always know where the upper limit of the thrombus is. So unless you know the upper limit of the thrombus, any clamp which you put might actually encompass the thrombus and you might break the thrombus. So it is always very important to keep an ultrasound handy. Now, I've already discussed how do you release the vascular clamps and how do you put up the vascular clamps. Now, if coming to the level 3 venous thrombus, so level 3 is the suprahepatic but subdiaphragmatic. So in these cases, you have to mobilize the liver completely. You have to divide the veins of the caudate lobe, which drain directly into the IVC. You have to identify the 3 hepatic veins, right, middle, and the left hepatic vein. You would definitely require a GI surgeon for this, because this requires a complete liver mobilization, and it also requires at times the Pringles maneuver. So Pringles maneuver is you basically decrease the blood supply of the liver by doing this Pringle maneuver. You clamp the hilar structures of the liver so that the inflow of the blood is not that much, and then once you clamp the IVC, the blood loss is not that much. So you have to mobilize the liver, you have to cut the triangular ligament, you have to cut the coronary ligaments of the liver, you allow the thrombus to be removed from caudal to the hepatic veins, and if it is not possible, then you might have to clamp the hepatic veins, but you have to go for a Pringle maneuver, otherwise this will lead to severe hepatic congestion. At times, if you find that the vein is involved, you might require to repair the vein. There are multiple modalities available. The most commonly used modality, if you have a pericardial patch, this the cardiothoracic surgeons usually have there available. Otherwise, you can use the gonadal vein to patch the IVC. Coming to the level 4 thrombus, that the thrombus is going supradiaphragmatic or it is going into the atrium. So this again needs to be done in centers of expertise, and you need a cardiothoracic backup. Again, an important question that what kind of bypasses do you use? So I will just go to the main slide for the lack of time. So there are 2 kinds of bypasses which you can use. One is called the veno-venous bypass, in which you need not open the sternum of the patient and you need not go to the heart of the patient. So you basically put in a catheter into the femoral vein and put in another catheter into the internal jugular vein, so that you have a complete veno-venous bypass. And then you can, without opening the chest, with the help of Fogarty's, you might be able to take the level 4 thrombus out. The other bypass is called the cardiopulmonary bypass, which we are all aware of. So the patient is put up with or without deep hypothermic arrest, and the blood is shunted out, and then you can proceed with complete thoracoabdominal incision and excise the entire tumor. So again, a very tricky question which the examiner might ask you: if you have to operate an IVC thrombectomy, which side of the tumor would you like to operate? So it has been shown that the right tumors are better to operate as compared to left tumors. Again, because you can clamp the left side vein very easily, you can clamp the IVC, you can divide the IVC, because the left kidney has collateral supply by which it can drain the venous blood. But if it's a left-sided tumor, the right kidney does not have any kind of blood supply by which it can drain its venous blood. So right-sided tumors are specifically better if you're dealing with an IVC thrombectomy. Again, if you're dealing with a patient who has a complete IVC or occlusion, this is usually because of a bland thrombus. So this might not require a complete resection of the IVC or a reconstruction of the IVC, because bland thrombuses can be left as they are, because the collateral blood supply is already developed. So you can just do a nephrectomy and leave the bland thrombus in situ. But the most important step is that either you put in a greenfield filter above it so that the bland thrombus does not embolize in future, or you basically pass a stapler and divide the IVC at above the level of the bland thrombus so that the thrombus does not embolize. Now coming to the second part of my talk is non-metastatic locally advanced. This has already been discussed, so I will just rush through the presentation. So any locally advanced tumor is a tumor which has either the involvement of adjacent organs, involvement of the psoas muscle, involvement of the colon, involvement of the liver, spleen, etc. So this is generally not very commonly found. It is just in 2 to 3% of the cases that you will find these such tumors. If the liver is involved, excise the liver. Duodenal involvement can be again a very tricky situation to manage. If the lumen compromises too much, then you might not be able to resect, and a complete Whipple's might be required. Pancreatic invasion, again, a Whipple's might be required along with a nephrectomy. Colon and mesentery can be easily tackled. You might require a resection and anastomosis for these tumors. Again, an important slide for the exam going students. So what are the differential diagnoses for patients who have abdominal masses? Large upper quadrant abdominal masses. So your differential should be, it can be an RCC, it can be adrenocortical carcinoma, urothelial carcinoma, lymphomas are again common in that area, or a retroperitoneal sarcoma. And then depending upon how the case progresses, you can exclude these from your differential diagnosis. So for the locally advanced tumors, again, surgery is the potentially curative management. If you're able to excise and give a R0 resection, these patients will have reasonably good prognosis. But since the tumor is already a T4 tumor, again, the overall outlook does not remain very good. And these people tend to have systemic or local regional recurrences very soon. What is the preparation which you need? So you have to have a comprehensive preoperative consent. That is extremely important. You have to tell the risk of morbidity, mortality, need for resection of adjacent organs. You should think about getting the bowel preparation also done, though it is not very mandatory these days. Preoperative embolization, again, a very important viva question. You should consider preoperative embolization. Specifically if you have larger tumors, specifically if you have arterialization of the thrombus, specifically if you have a lot of collaterals, or you have a lot of lymph nodes which are there, which are encasing the hilum, and so that the approach to the hilum might be difficult. And if you're planning for a splenectomy in a planned surgery, you can again think about vaccination with the capsulated organisms. As it was already discussed by Raj about the role of lymphadenectomy, it is a controversial, it holds a controversial status. We usually do a lymphadenectomy in patients who already have a clinically discernible node. If the node is there, we tend to take that node out, or maybe do a very limited resection of the lymph nodes. If the lymph nodes are extremely extensive, you might actually leave the lymph nodes behind, because it would not be possible for you to give an R0 resection. So it was also found that the right-sided tumor, the kidney tumors do not have a very fixed pattern of spread. So you might have a spread which is in the interaortic groove on the right side, and there might be nothing on the hilum. You might have a spread which is on the pre-aortic area or a para-aortic area, again, nothing in the hilum. So lymphadenectomy, as of now, does not encompass a very standardized treatment during the management of even locally advanced RCCs. But my take-home message for lymphadenectomy will be that if you have nodes which are visible on a preoperative CT scan, you should endeavor to at least take those nodes out rather than doing a formal lymphadenectomy. Thank you so much. I would wrap up my presentation with this. Thank you.
Thank you very much, Tarun. I think this was a very exhaustive presentation, and obviously your topic was large, so I did not interrupt you. I think, thank you. There will be a lot of opportunity to discuss these surgeries when we are discussing the cases tomorrow. So, Dr. Kumar, Professor Kumar, if you have any comments to make.
No, it was a very nice presentation, very elaborate and very explanatory. Okay. Congrats, Dr. Tarun, for the nice presentation. And we are running short of time, so we should move ahead.
Yeah. So yes, Dr. Sharma will now present on laparoscopic partial nephrectomy, and
My slides are visible.
Yes, yes.
Okay. So I have got a topic to discuss laparoscopic partial nephrectomy, particularly for the small tumor. So starting with, we have two approach, transperitoneal as well as retroperitoneal. Transperitoneal, we are very much accustomed to do it. Retroperitoneal, it is better or more suitable for the posteriorly placed tumor, and particularly near the hilum. And very few persons are doing this retroperitoneal surgeries nowadays. So the primary goals of the surgery is complete tumor excision with negative margin. There should be adequate hemostasis, and we have to monitor warm ischemia time in laparoscopic nephrectomy, partial nephrectomy. So there are 7 steps for the laparoscopic partial nephrectomy. First step, initial access and port placement. Second, creation of the renal hilum. Third, tumor exposure. Then we clamp the renal hilum. Then tumor excision. Then ultimately rhinorrhaphy with hemostasis. And then at last, after removing the tumor, laparoscopic exit. Okay, so the first position of the patient. Here we use modified flank position, operative side tilted up 45 degree like in this photograph. Port position regarding left side tumor, left kidney tumor. This is camera port, 5 mm port. These are 2 hand port, 1 extra port for the assistant irrigation or retraction. For the right side tumor, this is camera port, this is 10 mm port, this is left hand port, and this port is for the liver retraction, and this is again assistant port for the suction irrigation and other ports. For obese patient, if the patient is very obese, these port placed laterally because of obesity. These shifted laterally. So the first step is after entering gut mobilization to expose the left kidney. Here in this photograph, you can see this is gut, large gut, left-sided tumor. We have to give incision in this line of Todd to remove this gut, colon, descending colon. Like this, here the colon is moved and this part is Girota. The next step is to differentiate between the peritoneal covering as well as Girota and give an incision here to remove the colon. On the right side, you have to retract liver like this, and this is upper polar incision in the hepatorenal, this ligament. Then on the, this is again on the left side, the next step is to lift the lower pole of the kidney and try to make a window to see the psoas muscle. Here is the psoas muscle you can see. And you have to follow this psoas muscle cranially. Just like here. You have followed psoas muscle cranially. On the left side, lower pole is lifted up. You can see the ureter is lifted up to reach up to the hilum. You can see here, these are the hilar structure, renal vein and arteries there. So you have lifted and you have reached up to the hilum only just by following the psoas muscle. Then coming to upper pole, on the left side, spleen mobilization is there. Splenorenal splenocolic ligament is incised, and after incision, you can find by the weight of this spleen fall away, and you will get a very nice upper pole here. So you have mobilized lower pole, upper pole, reached up to the pedicle. Here is a small video for the right side laparoscopic partial nephrectomy I have done a few months ago. This is the how we prepare the hilum. So this is the hilar structure. We are making 2 windows for the right side. Here is the one window, another window, one above and one below the pedicle. Then you can again separate the artery as well as vein separately, so that if you want to place a this bulldog clamp in only in artery, then you can place it. Or en bloc, en bloc occlusion, if you want to do, then you can place a Satinsky or Bulldog here. Then the next step after this hilar dissection, you have to localize the tumor. So how you will localize the tumor? By direct inspection, and you have ideas from the preoperative CT scan. And then you can use intraoperative ultrasound probe. Very few center is having and they are using. And particularly these ultrasound, intraoperative ultrasound are very useful for the endophytic tumor. This is the ultrasound probe, and the tip is movable. And there is one review article, intraoperative ultrasound for the nephron sparing surgery in patient with technically challenging tumor, and they got more than 90% negative margin rate comparable to exophytic tumor if when they used intraoperative ultrasound. So here, tumor exposure, again, have a short video of this. First, we have to do defatting to expose the renal capsule. Here is the tumor and we are doing defatting. This is the renal capsule. This video are for the right side. And after doing this defatting, you have to delineate the tumor. Fat above the tumor, you have to left, and away from the tumor, you have to remove. Then this is the tumor. You have to mark around the tumor by using cautery. In this photograph, you can see this is the tumor in the lower pole with the overlying girotas fat, and here defatting was done. You can mark with using this cautery, either monopolar, bipolar, what you have. So this is tumor marking. So there is a small video clip of tumor marking that I am doing. So this is the tumor along with the girotas. I am marking the tumor. I have this bipolar. So I am marking with the bipolar. Or you can do with scissor, or you can do with hook also. So, sorry again. So you have marked the tumor. Now you are going to clamp the tumor and cutting the tumor. So before doing that, we have to checklist. We have a checklist, and we should see in our trolley or scrub whether the clamps are ready, sutures are ready, clip applicators are ready or not, lap Satinsky is working properly or not. And we ask our anesthetist to see the vitals of the patient and to pre-hydrate around 3 liters of the fluid, because when you cut the tumor, there is back bleeding. Even if you clamp the artery, there is a chance of back bleeding, and there is some amount of bleeding. So pre-hydration is very important. Again, you have to see the blood products, whether blood group is available in the OT or not. Then ask your staff to see the check check your gas cylinder, because you while cutting and while suturing, if gas is exhaust, or then there will be problem, because you have a warm ischemia time, a limited time. So you have to checklist all these things. You ask your assistant to clean the camera port, check the suction and other instrument whether they are working properly or not. If only after this checklist, then move ahead. The next step is en bloc Satinsky. It's 9 o'clock. Here you can see this is the photograph with tumor. Here you have to do clamp. In this photograph, left side, Satinsky is applied to the hilum. Again, I have video of the same tumor where I am applying Bulldog. See, en bloc hilar clamping is being done. This is how I have clamped. Now my time, warm ischemia time is started. So I have to be prepared to do my job quickly. Sorry. So what are the methods of hilar vessel clamping? Laparoscopic Satinsky clamp, faster en bloc clamping requires an additional 10 to 12 mm port, but there is a risk of inadvertent slippage. Not useful in retroperitoneal approach because of less space. You can use bulldog clamp. Application requires artery dissection, and technical difficulty in manipulation may increase warm ischemia. You can use vascular tourniquet. It does not require additional port, not limited by number of vessels, can be left in situ after reperfusion or emergency reocclusion if needed. Here are the photographs by how we are applying the vascular tourniquet in the right artery and the vein. So the next step is tumor excision. What is enucleation? What is resection? So this is again a viva question. Enucleation, when you remove the tumor along with the capsule, this is enucleation. What is resection or excision? When you remove the tumor along with a rim of this renal parenchyma, then this is resection. So we are doing here resection. You can see this is the resection. Again, I have one video of tumor resection. The same tumor, you can see I am excising after the clamping of the hilar vessels. Here, the assistant is using this suction because there is a back bleeding. You will find some difficulty initially, but as soon as the vision is good, you give a cut to the structure. You can see your assistant role is very important here to irrigate as well as suck the thing. You can see there is a small vessels that I am cutting, and at the same time you can see the scissor curve is is away from the tumor, so that I can manage or keep the rim of the renal parenchyma adequate. Okay, this is how we are cutting. So my assistant is doing a good job. He's flushing as well as lifting the kidney. This is how ultimately the tumor was excised. Now there is a tumor bed you have got. You have to stitch the tumor bed. Sorry. This is called rhinography. Rhinography generally we do in two layers, inner layer as well as outer layer. Inner layer like this, you have to close the pelvic calyceal system if it gets opened up, or you have to close the renal vessels like renal vein or artery if you have cut that artery or vein. So inner layer rhinography, as well as then again after doing this inner layer, outer layer apposition of the renal parenchyma or cortex should be done. So again, I have a video of the same operation. This is how I am doing inner layer rhinography. You can see. You can give a simple closure, simple surgical stitch, or you can give a figure of it that will be better to close the artery or vein if there is. And if you have opened up the pelvic calyceal system, you must close the pelvic calyceal system. Otherwise, post-operative leakage problem will be there. So this is how I'm doing inner layer closure. This is interrupted closure, interrupted suturing. I have seen some person is giving the continuous suture also. I'm using Vicryl 20. You can use barb suture in inner layer also. But for the continuous suture, barb suture will be better. This is how inner layer is being closed. Again, after giving this saline flush, you have to check from where oozing is still there. Then again, you have to close. Now, this is edited video. I'm giving the outer cortical suture. Here, I am using the barb suture. Barb suture. For the stability of the suture, I am using hemolock clip, so that after compressing or this tissue of the cortex or the kidney, I'm locking the suture. Although this is barb suture, it can itself lock, but for the safety purpose, you can use this hemolock clip. This is how ultimately we are giving outer cortical suture. No, finally find the clamp. No, after giving this rhinography, you have to remove the bulldog clamp to see whether there is any bleeding or not. If there is no bleeding, the job is done and you can proceed. Okay. So next, some people are also using bolster, this Surgicel placement in between the suture. But nowadays, most people are not using this bolster. Then this is the last video, how to catch the tumor in the surgical bag. This is customized bag that we are making in our OT with a sterile plastic bag. And we have to remove the tumor from the body. Oh, sorry. So regarding warm ischemia time, it's very important. Traditionally, safety limit of warm ischemia time is around 30 minutes. And various study was done. And they found that each additional 10 minutes of warm ischemia associated with 2.5% decline in recovery from ischemia. But one thing I will tell, that when you will do lab partial nephrectomy, don't watch your clock. So when you will be hurry after watching this clock, everything will be messed up. So don't watch the clock, do your job nicely. You will do better. Thank you. Thank you very much.
Thank you very much, Raj. I think there's another presentation on laparoscopy from Samir. Would Samir, Dr. Swain, would you please share your presentation, and then we can have one or two questions before we conclude for the night.
Good evening, sir.
Good evening. Dr. Swain will present on laparoscopic partial nephrectomy on complex mass and the specific and important steps of these procedures.
So my slides are visible, sir? Hello?
Yeah.
Yes, you're visible.
Yes, sir. So Dr. Raj has almost completed all the steps and points to be taken into consideration for laparoscopy partial nephrectomy. So though this forum is for students for exam going, but for the sake of completion, this topic has been given. So again, the principle and requirement for the surgeries are thorough patient's evaluation, counseling, then patient characteristic has to be taken into account, like obese patients, short stature. We must predetermine the port position as per the imaging, and detailed study of imaging means location of tumor and its correlation to the body habitus, as well as CT angio to ensure the relationship with the vessels to the mass and the halo. So in dealing with the complex renal mass for laparoscopy partial nephrectomy is really challenging, and many times we should be ready to convert it to radical or maybe to open. Regarding position of the patients, instruments, endovision system, rescue measures, already Raj has told, and ports. So this is one case. I just want to highlight two cases how to manage in this type of situation. This is one case we can see the hilar position of the posterior aspect of the kidney almost behind the vein, and on the coronal section it's almost medially placed. So this is one port position, typical port position, and this may be considered in majority of right side tumor, just like standard nephrectomy. These are the two additional ports may be taken. So coming to the video, this is the same case that I have already discussed. Initial dissection of hilum is important. Initial dissection to the mass to be dealt is important. These are the two aspects which must be taken care. In this case, all around the hilum has been dissected off because I should be prepared for any catastrophe to convert it to radical. The kidney has to be flipped. This is a complex and posterior placed hilar mass. Initial dissection of the heart. And all these points have to be taken into account specifically to localize the mass. Now you see the vein is stretched up and the mass is almost compressing the vein. Artery and vein has to be clamped. Now we can see the mass almost overlying the renal vein. Marking has been not that much important in this type of situation because it is almost endophyting and partly hilar. So marking is not possible most of the time. So initial dissection has to be done. This is almost encroaching to the calyx. So now the calyx is opened up. In this type of situation, deliberately opening of the calyx and dissection of the mass is done. Now you see the calyx has to be totally divided. Next, towards the hilum, it is almost sitting on the vein. So one vein is almost dissected. Now we can see the opening. Second, vein and part of arterial branch has to be tackled. If possible, in this type of situation, if you need, can give a clip or hemolock, if at all feasible, or else we can go for suturing. Now towards lower down, the mass is almost encroaching towards the pelvis. Now part of the pelvis has already involved, so it has to be excised also. Now we have repaired the vein, taken into position not to go deep, because here the vein is partially clamped. So rest of the part has to be taken care in serial suturing. Now you can see the almost there is no definitive bleeder is seen or definitive lumen is identified. Now next point is to close the calyx. Now in this type of situation, we have a plan to completely close, encircle the calyces, calyceal part. Now in these patients, the pelvis has been opened. So I put a DJ stent. Of course, there is a question to place preoperative ureteric catheter in this type of situation. That is also fairly good. And finally, our plan is to go for suturing of the pelvis. And finally, the suturing of the parenchyma in a circular manner. That means just like closing in a marsupialization manner. That means part of the calyx, part of the parenchyma, and it's throughout all around. Now you can see we are closing the parenchyma particularly, but not going towards the medial part, means we are just avoiding the hilum. After closure of all the aspects of parenchyma, that means it is just like marsupialization of a cyst. At the same time, making it CO to take hemolock clip as and when required. Barb suture are being used in this type of situation. After completion of suturing all around, now this is the final suturing towards the lower aspect. Now it's cleaned, area has to be cleaned. There is no definitive major bleeder seen. There is a small bleeder that is also tackled. Now finally, the artery and vein has to be declamped. Now in this type of, now this is a situation why I am telling, sorry. So dealing with a hilar mass, majority time, there is a possibility of small buildup. So it should be prepared beforehand. So all rescue measures has to be there. So now you see there is a small buildup from the hilum, that means small branch has been missed. So it has been carefully tackled with placement of another hemoloclip. So now the bleeding is gone. So in this type of situation or complex renal mass, now you can see the kidney is almost well vascularized without any definitive bleeding. So dealing with the complex renal mass, always we should be prepared for the catastrophe to convert it to a radical. This is another video I am showing. This is a case of almost majority part of endophytic mass encroaching to the infracalyx, and almost the mass is projecting to the infracalyx. Now you see initial dissection has been done all around the lower pole. Hilum is dissected. Now you see there are two branches of artery and vein are going towards the lower pole. So these two vessels are to be tackled in proper way. Initial marking has been done. All the steps are already been described by Rajkumar, so I am just skipping this part. Now you can see partially exophytic part of the lower polar mass. So both the artery and veins are clipped before going for partial nephrectomy, because there are two separate vessels going inside. Now artery and vein are clamped separately. I don't go for mass clamping just to have a practice and to avoid the sequestration of blood. Now you see initial dissection has been done. In this type of situation, again, deliberately the calyx has to be opened. So going towards the hilum means sinus fat, then calyx is identified and deliberately opened. Now we can see the mass projecting in. Now we can see the mass projecting inside. Calyx, the mass is seen just at the tip of forceps. Then dissection all around the tumor tissue has to be removed. The calyx is repaired separately, and two-layer closure, that means inner layer and outer layer closure of the kidney is done. This is with barbed suture and intermittent placement of hemoloclip without any bolster, and we used to place some final fat closure above the kidney. So now dealing with complex renal mass is now not a problem. Its only issue is to see the location of the mass, size of the mass, its feasibility or preoperative identification of the plane to be dissected. And in times maybe intraoperative ultrasound is helpful, but complex renal mass is always challenging and it's a difficult situation. Any catastrophe is possible, should be prepared. Now you see this is the mass dissected specimen with the protruding mass to the infracalyx. And this is the specimen. Then after cut upon the specimen, the mass is protruding but not invading the calyx. Thank you, sir.
Thank you very much, both Raj and Samir, for excellent presentations. So are there any questions from the faculty, from the students? And any comments from Professor?
All the presentations were very nice, especially the operative ones. I think the purpose is served after this class, I think.
Yes, sir. For the sake of completion, these has to be done almost nowadays. All the students should know the basic steps of open surgery has to be learned. Second is now laparoscopic radical nephrectomy and laparoscopic partial nephrectomy, easy renal mass. But they should not be bothered to answer that I will be preferring to do it in open methods. So laparoscopic method is okay, but in exam, it is not mandatory that all students must answer in laparoscopy way. Open is the method that has to be adopted. And I think partial nephrectomy and radical nephrectomy doing laparoscopically is nowadays very common. So all the students should know the basic steps.
It has to be accepted as it is here to stay. There is no confusion. I think all the speakers deserve a lot of congratulations. And also we are thankful to our moderator, Dr. Kalyan Sarkar. He has done a wonderful job.
So thank you very much. I think we enjoyed all the presentations, and I think certain points were made and very good take-home messages have been obtained. And I think we should conclude for this evening. And tomorrow there is a case discussion session and a quiz. So we'll assemble again tomorrow. And I'll hand
10 o'clock.
At 10 o'clock, and I'll hand the proceedings over to our President and Secretary to conclude the evenings.
Thank you, Dr. Sarkar. It's a very exhaustive discussion, almost everything related that can be asked for an examination, and students are very fortunate to get such a good outline of preparing themselves for the examination. I must congratulate all the teachers. They have given a lot of effort as a mentor, also as a teacher, and at the same time students, they have prepared their presentation quite up to the mark. I hope tomorrow clinical case discussion will be of great help with the help of today's knowledge which has been given and discussed. So with this, I thank all of you once again and hope to, and I must singularly thank Dr. Kalyan Sarkar and also our very senior veteran teacher, Dr. Vijay Kumar from Patna, for taking much interest in conducting today's show. And tomorrow also we will hope students will get benefited with the discussion what they will have for the upcoming final examination they are going to do. Thank you very much. Thank you, everybody. We're going to meet all of you tomorrow by 10 o'clock.
Thank you, sir.
Thank you. Thank you, everyone. Thanks to all the faculties and students and organizers. Thank you.
Thank you so much.
very much.
Good night, sir.
We'll meet tomorrow morning.
Yeah. Thank you. Bye.